Precocious puberty. So precocious puberty means onset of puberty less than 8 years, and the most common cause for this precocious puberty is idiopathic. And there are actually two types of precocious puberty, that is central precocious puberty and peripheral precocious puberty. In central precocious puberty, there is a premature activation of the HPO axis, that is hypothalamic pituitary ovarian axis. So if the precocious puberty is due to premature activation of HPO axis, it is called central precocious puberty. In peripheral precocious puberty, there is no activation of HPO axis, but the sex hormones will be present. So regarding the central precocious puberty, 90% cases of central precocious puberty is idiopathic, but in 10% females it can be due to a brain tumor, and the most common brain tumor causing central precocious puberty will be hematoma. The other brain tumors causing central precocious puberty will be glioma, meningioma and ependymoma. So how to differentiate between the central and peripheral precocious puberty? In central precocious puberty, LH and FSH will be high. Peripheral precocious puberty, LH and FSH will be low due to feedback inhibition. In central precocious puberty, the changes always corresponds to genotype, that is, it is isosexual, whereas in peripheral precocious puberty, the changes can correspond to sex, that is opposite sex. Like for example, in congenital adrenal hyperplasia, there is an increase in androgen, so the changes observed in this female corresponds to that of the opposite sex, that is male. And the treatment for central precocious puberty will be treating the patient continuously with GnRH agonist, like for example leuprolide, that is goserelin, boserelin, nafarelin, etc. So when the patient is given continuous administration of GnRH agonist, initially there is an increase in LH FSH, so that is called as flare response, and consistent increase in levels of LH FSH will cause feedback inhibition and suppress the HPO axis. So regarding the peripheral precocious puberty, there is no activation of HPO axis, but the sex hormones will be present. So causes for peripheral precocious puberty include tumor, congenital adrenal hyperplasia, McCune-Albright syndrome, and long-standing severe hypothyroidism. These four are the main causes for peripheral precocious puberty. So here McCune-Albright syndrome consists of a triad, that is peripheral precocious puberty, capsulite spots, and polyostotic fibrous dysplasia. In long-standing severe hypothyroidism, there will be increase in TSH, so that will cause increase in FSH-LH, which will stimulate the ovary. So in central precocious puberty, the patient is treated with continuous administration of GnRH agonist. So there are other conditions in which GnRH is given continuously. They are fibroid, endometriosis, then precocious puberty again, and then hirsutism, heavy abnormal uterine bleeding, breast carcinoma, prostate carcinoma. Route of administration of GnRH agonist will be for continuous supply, the GnRH agonist can be given as subcutaneous injections and nasal sprays. For pulsatile supply of GnRH, it is given in the form of IV infusion pumps. Pulsatile GnRH is used in treatment of delayed puberty and infertility for ovulation induction. The GnRH antagonist can also be given. So the GnRH antagonist is cetrorelix. Here there is no flare response, and the newest drug is elagolix oral drug. So the elagolix oral drug is used in endometriosis and fibroids, and the mechanism of action of this elagolix will be suppression of HPO axis, and the indications for elagolix use is the same as that of continuous GnRH agonist.